Okay, so we are officially beginning our webinar, and I would like to introduce Miss Karen Carothers. I'm going to let her tell you a little bit more about her role with Zero Suicide, but she was hired by one of my favorite people in the entire world, Tom Starling, the CEO and president of Mental Health America of the Southeast. And we have been partnering together, just the two of us, for the past couple of months, just getting to know each other and working on how Zero Suicide will fit in the framework of TCCN and how TCCN will fit in that framework that Zero Suicide is bringing. And Karen has actually become one of my close friends in the past couple of months because we've spent time together talking about mental health face to face. And so of course, she's become family. So I'm going to turn it over to her. Please start at the beginning, Karen.
All right. Well, good afternoon, everybody. Thank you for taking the time to spend some time with me so I can talk to you a little bit about the Zero Suicide Program and just, a little quick introduction about me. I actually began working with Mental Health America in October the 1st, and came on to help develop this new program. So I'm really excited about that. My background actually is in rehabilitation counseling. So I've worked with the state for several years, working with people with disabilities and work for 10 Care. So sort of a broad background that I'm bringing in together, and just super excited about this program and what it offers to our partners and people who are working in behavioral and healthcare settings. And I do love Mary very much. Fell in love with her very quickly. So I'm happy to be family. So yeah. If you, I'm going to share my screen and just move through this fairly quickly so we can have some time for questions, and hopefully my technology is going to work here for me. Can you see that? Fantastic. Okay. All right, just a quick overview of the grant. It is a 5-year grant that was awarded to Mental Health America of the MidSouth, and it's funded by SAMHSA. And Zero Suicide is not a program that, of course, MHA, that's Mental Health America, in case I say that, that we created. It is a national evidence-based model that was designed by the National Alliance for Suicide Prevention. And actually it's being implemented both nationally and internationally. So it's broadly being used. The program includes 6 primary partners, which we are very excited to have on board with us: WellPath, HCA, Core Civic, the Refuge Center, which is the only one of our partners that is sort of local, but it's a large facility in Franklin. And then of course the TCCN network and Spiro Health. So those are our primary partners in this grant for the initial 5-year period. And because it's funded by SAMHSA, the model itself is very well defined. So there are specific steps, specific components that based on the evidence-based model that you would implement. But SAMHSA has allowed us to add another component, which we're calling resource navigation services, where when our partners refer individuals to us who are transitioning back into the community and may need resources in many different areas, whether it's employment, childcare, you name it, that we will be able to support them in that, and hopefully be able to make some referrals so that they can make those connections. So that's an added little bonus to the program. Quickly, for people who work in the behavioral health, mental health arena and healthcare, I'm sure this is not new information to you, but I just want to point out where you see the blue bars, that what we know is that death by suicide is the second leading cause for individuals who are between the ages of 10 and 34. This is national data, and it's from 2018, because of course, as you know, the data is usually a couple of years behind. Ages between the ages of 35 and 55, it's the 4th leading cause, and then so on. Between 55 and 64, it's the 8th leading cause. And then of all ages, it is actually the 10th leading cause of suicide. of death in the nation. Closer to home, just a few facts here. It's the third leading cause for ages 10 to 24, and it remains the second leading cause for individuals who are between the ages of 25 and 34. And then fourth leading cause for individuals between the ages of 35 to 44. And you can see the other ages. I won't go through all of those. But on average, what we know in Tennessee is one person dies by suicide every 8 hours in our state. And individuals are almost 5 times more likely to die by suicide than in alcohol-related motor accidents. And you know, given the what's happening now with the pandemic, with people being isolated, with unemployment, we're seeing, even though the data's not out yet, I think we can see that those numbers are increasing in terms of the numbers of people who are dying by suicide. So when those statistics come out, it's we're probably going to see a significant increase in the numbers. So just to give you a little idea, overview, the mission of the Zero Suicide Program is basically, it's a transformative approach to providing healthcare services for people who have suicidal thoughts. And it's based on specific framework, specific practices, with the hope that healthcare settings will be safer and more compassionate when working with and supporting people who may have suicidal thoughts. And it's designed on a zero-based mindset because the hope is that once you implement the program and the components that I'll talk about in just a little bit, that you will see zero suicides within your organization. Most of us, or most individuals, when you think about addressing the issue of suicide ideation, you think about behavioral health, and that the providers of behavioral health services are going to be the ones that are actually going to address that issue, identify it, address it, and provide the treatment that's needed. But what we know is that individuals who have thoughts of suicide, who may have attempted suicide, and who die by suicide, have reached out in other areas. What the research tells us is that 50% of those individuals saw a general practitioner at least a month before their death. Now, they may not have come in, and that may not have been the conversation that they had, but they were in that office. 30% of them saw a mental health professional within a month of their death by suicide. And 2 months prior to that, 10% of those folks were actually seen in an emergency department. So we know that individuals who are contemplating dying by suicide or have thoughts of dying by suicide are actually being seen in various healthcare and behavioral health settings. So what happens many times is that the question, the specific question, are you thinking about killing yourself, is not asked. And that's for various reasons. And those reasons are sometimes the person's just, they're fearful to ask because they won't know what to do if the person says, yes, I am having thoughts of suicide. They're not trained. So they may not be afraid to ask the question, but again, it's, you know, what's the next step in terms of how we will address it in our organization. Again, they don't know what to do in that situation. And many times the person may, or the staff person or a person that's talking to them thinks the person is just going to tell them. And that's not going to happen. With the Zero Suicide program, the model, one of the things that the model does is ask the workforce, what do you think about, you know, working with people who have thoughts of suicide? What are your values? What is your experience? What do you need? And one of the things they use is a workforce survey. And they and the Alliance did this survey with more than 35,000, excuse me, individuals in 9 different states. And what they found was 35 to 45% of those individuals responded by saying that they didn't have the skills to engage and assist those individuals. 40 to 50% of those people who responded said they didn't have the training. And then 30 to 40% of those individuals felt that they lacked the support. And in saying that, they were saying that their organization didn't have the protocol, the policies to tell them how to do it. And they didn't know where to go to get that information. So they didn't feel like they had the support to address it if that issue was one that they had to deal with. So we know that there are things that need to be in place in an organization so that people don't fall through the cracks, and so that there is a process in place so we can actually identify those people and catch them, hopefully, and prevent their deaths. So just an overview of the program. As I said, it's a evidence-based, statistically proven model for best practice. It's been implemented for years in different organizations and agencies, nationally and internationally. I've been on the listserv, so I'm getting a lot of information from people from all over the world. Had sort of a little chatter back and forth with someone from Australia the other day who provided some good resource information. They've been doing the program for several years. So they found that the model actually works in the prevention of suicide. It's a framework for a systematic process in behavioral and healthcare systems. The program was actually designed to work with behavioral health and healthcare systems, although it is being used in schools and it's being used in prisons. A couple of our partners actually are working in the prison system and will be implementing the program. But it provides the basic information you need to be able to develop an organizational approach to suicide prevention. It's a continuous quality improvement process for transforming suicide prevention within an organization, meaning that you also put in an evaluation component. So you're constantly looking at, are we doing what we intended to do? Is it having the effect that we hope that it would have? Are people actually receiving the treatment that they need? And are we seeing the incidences of death by suicide actually decrease? And it's a transformative change that can't be born particularly or specifically by one unit, by one person, by one department. It really is looking at an entire organizational approach. So really transforming how that agency or organization looks at suicide prevention. And it's a long-term commitment by the leadership, because you're creating a culture where people know that this is important. This is going to be part of our mission. We're going to actually try to identify people, make sure our staff are trained, and that we can provide the support people need. And long-term commitment, it's a long-term commitment for us with our partners as well, because as I said, it's a 5-year grant. So we intend to be with our partners for a very long time to make sure that things are going well. How do we know it works? So we went back to a couple of the institutions that have been implementing the program for several years, one being the United States Air Force, who implemented the program. And what they found was that their suicide rate dropped by a third over the 6-year period that they were looking at it in the evaluation study. Henry Ford saw a 75% decrease in suicide in a 4-year period, and 10 consecutive quarters, there was no incidences or no reports of suicide. This chart, I hope, sort of provides a good overview, sort of comparing what a system that doesn't look at it from an organizational perspective, comparing that to one that does, using the zero suicide model. So if we look at the perspective of potentially an organization that is not implementing zero suicide or not taking an organizational approach, what we see is maybe the thought that attempting suicide is inevitable, meaning that if a person wants to die by suicide, there's not much that we're going to be able to do. And we know that people who attempt suicide and die by suicide really don't want to die. They want the hurting to stop. So if we look at it as every suicide in a system is preventable, then if nothing else, your mindset changes and you're really thinking about what can we do to ensure that it doesn't happen. Again, we're talking about within the organization, not nationally or internationally. Of course, that is a goal and should be, but we're talking about within, say, your particular agency or organization. Assigning blame. If there's an individual that is in your care and that person does die by suicide, not really looking at who didn't do or blaming the person or the staff person who may or may not have caught something, and instead really looking at the actual organization and holding the organization accountable instead of the individual or the staff person. By doing that, you're looking at making sure that the supports are in place and that there's a blame-free environment known as what Zero Suicide calls a just culture, so that everyone is free to provide input in how you can implement the process, and everyone knows that we need to work together to make sure that this is not something that continues to happen. Risk containment, risk assessment and containment, basically saying, if we identify someone who's having thoughts of suicide, we make sure we find that out and we move them on to where they can get assistance, again, depending on the behavioral health network to handle that. And looking at it from a zero suicide perspective, really looking from a collaborative safety, treatment, and recovery process. And by that, it means developing relationships with those organizations so you can have a smooth handoff for the person. From the shift in having standalone training and tools to actually having an overall system and culture change so that everybody understands what we're using to identify people. So from a zero suicide perspective, there is a standardized assessment that's used, whether it's the PHQ-9, the Columbia, whatever you choose to use, but everyone knows that is the assessment that the screening that you use, and that everyone is trained on that. And if the person screens high enough, that we can immediately get them to someone who can do a full assessment and move the person along as they need to. Specialty referrals and where potentially, if you're not looking at it from an organizational perspective, to niche staff, again, saying that behavioral health should handle that instead of from a zero suicide perspective, saying it's part of everybody's job. Everybody needs to be aware of it, everybody needs to be focused on it, and everybody needs to play a role in addressing it. From individual clinician judgment and actions to, again, the standardized screening, the standardized assessment, looking at specific interventions that you're going to use as an organization. Again, I have to keep reinforcing this is from an organizational perspective. From hospitalizations during episodes of crisis to really looking at the person throughout their care and the continuity of care and making those connections so that you're in some ways following that person along. And then the most important one, if we can save one life, sometimes, that's the perspective. If we can just save one life, that's great, that's wonderful, thank goodness. To really, within our organization, how many deaths are going to be acceptable to us? None. That's why, it's basically called zero suicide, because we have, as an organization, taken the perspective that no death is going to be acceptable within our organization. So that's sort of a comparison between the two. Zero suicide has 7 components. I'm going to go through each, so I won't spend a lot of time on this slide, but the leadership is on board, the staff are trained, we have a way to identify those individuals, we can get them involved in their care, we provide treatment that's appropriate for them, and then we help them transition to an appropriate long-term provider or community provider or whatever they're needing. And then we as an organization look at how we're doing that and how well we're doing it. So those are the seven components of the Zero Suicide Initiative. So when you're thinking about the leadership, this is probably the most critical component in my mind as I begin to work with the initiative, because as we know, in an organization, it starts from the top. It starts from the head. If they are committed to it, if they communicate that to staff and to their partners and people they're working with, then everyone knows this is something that we've all got to be thinking about and we've all got to contribute to. So it's very important that the leadership, the executive director, the president, CEO, whatever it is, not only understand what the initiative is, but that they're committed to it. They see the value in it and they want to make sure that it's done and done well and appropriately within the organization. So this means that that person or whomever's the lead person will introduce the initiative to all the staff, whether it's by email, it's a video presentation, a conversation, however, so that everybody knows this is something that we're going to be doing. We're going to be implementing this in our organization. Then that leadership supports the development of a zero suicide team, what we call a task force, who will sort of guide the organization through it to make sure that all the pieces are in place and that all the things are done that need to be done so that the program is implemented efficiently and effectively within the organization. The way that you get to that is by completing what's called an organizational survey. And this basically just looks at your organization in total. How are we doing? Do we have certain things in place? Do we have protocols in place? Do we have staff in place? Do we have the treatment in place? So you're looking at your organization across the board to see what do you have in place right now that deals with suicide prevention. The next piece is a workforce survey where you ask all of your staff to participate in the survey, take the survey. And what this does is basically ask them, as I said, what do you know about suicide prevention? How do you feel about it? Are you comfortable addressing the issue, asking the question? Have you ever worked in an arena where you had to address? So you're really getting a sense of what the staff, what the employees know about this. And this is going to help you figure out what training you need to provide to help them become competent and confident in addressing the issue. Then you're looking at, of course, your institution-wide policy and what policies you have in place and whether they need to be revised and updated or whether you need to create new ones. And after you've sort of taken a quick glance of your policies, from that information, you're able to develop an organization-wide implementation plan. I like to call it a strategic plan, and I know most organizations have one. So this is very much akin to that. And I love strategic planning. So I think this, that's an important piece to have. Under training, as you might imagine, is making sure that your staff are trained. that they understand not only what you're going to be doing, this is something you're going to be implementing in your organization, but that they know what zero suicide is. So it's basically maybe doing, what I'm doing for you now, doing a quick overview of what it is so they can get a good sense of what the model is and how it's going to impact them as an employee. Again, that workforce survey, you're assessing their beliefs, their training, what they know, and you're going to provide them with the training that they need appropriate for their role. And there are different trainings that within the initiative that we're going to be working with our partners, with you all, if you choose to implement it as part of your network, that we will be either providing or training someone to provide within the organization. We've already started with one of those. Hopefully you'll have someone that'll be able to provide some gatekeeper training for you. So that's a key part of it, making sure people are prepared. Under the identifying individuals, basically, as I said, you're developing or you're identifying a screening tool that everyone uses. Again, another training piece that everyone is trained on so that everybody's using it the same way. And then after that, if there's a positive screen, that we know what the protocol or the process is to immediately connect those individuals with appropriately trained clinicians. And then that clinician actually does the assessment to determine the level of suicide risk and to determine what to do next. Engaging those individuals, this is important, and engaging them in developing their care plan so that they actually have some say in what treatment, what services will be provided, and including that information. This is key, and not all organizations can do that, but developing something within your electronic health record that not only you can input that information, but when someone goes in to pull up a person's chart or their information, that there's some type of flag there. If there's been a screening that indicated that the person may have been at high risk, or if the person has reported that they've attempted suicide, that is there. So you already know that this is a person you need to provide that extra support to. And then creating a protocol that outlines how you deal with all of those situations, what you should do should you identify someone. Under treatment, again, this is important. We looking at people in the behavioral health arena addressing this issue. It's going to be very important, and making sure that there's safety planning that's done that not only talks not just a contract that the person won't attempt to commit suicide, but that there are steps actually in there that talks about reducing their access to lethal means. So there are specific things, and the person can talk to you about whether they own a gun, whether it's in their home, whether there's prescription medications readily available, or whatever that may be. So you're having that conversation, that becomes a part of the safety planning. That the care is provided in the least restrictive setting. If the person doesn't need inpatient hospitalization, that we are able to look at what other avenues we can implement to support them. And treating the person independent of a mental health diagnosis. This is something that's important. There are several different type programs and approaches that can be used that are specific to suicide ideation reduction. And as part of the initiative, we're going to be looking at either getting people trained so that they can support the clinicians in that avenue, or making sure you know where that training can be obtained so that people can really focus on the idea of suicide prevention and addressing that issue, in addition to if the person has a mental health diagnosis, because not all individuals are going to have a mental health diagnosis. And then, of course, individualization and collaboration.
It's just the mailman. No, yeah.
Transition.
Ash, you're not on mute. Sorry, Karen.
Oh, sorry.
No worries. Okay.
Transition, making sure this is another, they're all key components, so I probably keep saying that, but when the person, after you dealt potentially with the crisis situation, that the person has a smooth handoff to the community provider or wherever the next service is going to be provided. And that would mean that you might develop some MOUs with some outside organizations so you can make that phone call. It's actually making that phone call and making sure that person, before they leave you, has an appointment to go to the next place. So it's going that extra step and providing the follow-up after that. Some places, as I've talked to people again that are already implementing it, have developed little cards that they send to the individual that says, we're thinking about you, how are you doing? Give us a call. We're here if you need us, that kind of thing. Some are actually writing handwritten letters, so it's more personalized. So different ways to make sure you're staying in contact with that individual, particularly in the first 60 days after they are leaving your care, because that is what we know is a critical time. Educating the person on the model of care or on what they're going to be receiving, talking through that safety plan, and then of course monitoring, as I said. And then finally, the improve or the quality improvement piece of it, developing a CQI program to make sure that the model is of course being implemented as it should be, that the things are in place, evaluating that on an annual basis. And within the Zero Suicide Initiative, we are working with Elevate Consulting. They are our evaluators for this initiative, and they are supporting the partners and the organizations in not only in the development of this quality model, but also in analyzing the data that you would receive from the organizational survey and from the workforce survey, all of that data, synthesizing it so that it makes sense and you can utilize that to develop your plan. So again, another key component. So those are the 7 components. And ultimately what we want to do is the 3 C's here. We want to collaborate so that the systems are in place with stakeholders and other behavioral healthcare systems, emergency care. We want to connect the person who may be having thoughts of suicide to the resources that they need. We want to connect staff to the training that they need, and we want to connect the community partners so that there is truly a network or a safety net for individuals. And then of course, we want to conquer or eliminate community loss by means of suicide within your organization, again, because that's where you have control, for lack of a better word, to make sure that there's success. And we have within the initiative, the team, the Zero Suicide team, we have 3 coordinators. I function as the director of the program overall and also as the central region coordinator. So I'm working with those individuals. And then we have someone in our West region, someone in our East region, and then we have an assistant that kind of helps keep us all together. So if you have facilities across the state, we have individuals that can also support individual organizations as they begin implementation. So, and that's it. I will stop my share and see if we have any questions.